follow every CHNA to see if the needs are changing for our community over time.
Okay. Right. Thank you very much. Back to you, Chair.
Thank you. Dr. Merman, are you up and running again?
I think I'm good. Can you all hear me?
Can hear you, yeah. And
Great.
see you.
All right. Wonderful. Thank you. Long day already. Hopefully this isn't going to be, I think I mentioned last year at the end of this, I felt like I just did a 12-hour ED shift. It was like 8 to 8 or something. So this is going a lot better. So hopefully we'll get out of here a lot sooner than that. It was a very long submission, and I have just far more questions are generated by it than I think I can get through, and gratefully, Tom and Jess and Owen asked a lot of them. I think I'm going to start a little bit where Jess kind of left off, and Tom was talking about some of this data that we're talking about, and I had a similar response to the idea that that you could discount an entire concept of the cost shift based off the research being retrospective. Just to point out, pretty much everything that we're looking at in this area is retrospective. The Dartmouth Atlas is retrospective. Cooper's article is retrospective. Any price data that you looked at that happened yesterday is retrospective. So we're really dealing with a lot of retrospective research, and for the clinical people, Dr. Leffler, Dr. Epen, I mean, we use retrospective data all the time to make powerful decisions that are meaningful. So I would just be cautious of dismissing something purely because it's retrospective. I guess while on the cost shift topic, there was one other thing I wanted to ask, which is you cited this this opinion piece from Health Affairs. I actually read when it came out. I thought it was provocative, and it was a part of a two-piece opinion piece combo. And I was curious if you circulated this opinion piece that's the first item in your appendix with senior leadership, with the board, to sort of discuss the cost shift internally.
Remember, we do discuss the cost shift regularly, but we did not circulate this article.
I would strongly recommend reading the article that's paired with it by Ginsberg. I do think it's not a polar opposite article. I do think it tries to take a little bit of an opposing view as to that article, but it tries to be really balanced and sort of understanding that the cost shift is there and it's part of what's going on, but it's not entirely what's going on, and it discusses a lot beyond that. So that's just and I'm sorry, like the first bit here, I'm going to give some reflections from the hospital, from your really extensive submission, and then we'll get into questions. The other area is the Dartmouth Atlas, and I pulled up the Dartmouth Atlas in this time, and it's often used to say that it's low cost, but actually when you pull up the Dartmouth Atlas, it says it's low reimbursement. It's talking about an area with low Medicare reimbursement. And we've used the term cost, but it's really saying low reimbursement. I think we've talked a lot today about Medicare reimbursements, about sole community hospital status, about wage indices, increasing utilization that we're having now. We can see that in your budget actuals for FY24, that Medicare is, and actually, Owen mentioned in each of the years that Medicare revenue is exceeding your expectations, and it's probably utilization driven. So I just wanted to sort of throw that in there, that the Dartmouth Atlas is really shows that you have low reimbursement per capita, but why you have low reimbursement per capita is not explained at all by the Dartmouth Atlas. But it's retrospective, so you got to take it for what it is, because right now is very different than what it was. The Cooper article, I just want to also address, because Dr. Epen, you brought it up in your opening remarks. It's in a few different places in the budget submission. It's in the appendix, a discussion of it. I had a very similar take on it as Professor Holmes, that this really doesn't represent our insurers, so we really can't make much much about.
Dana, come here.
We can't really make many interpretations based upon the spending in our area because it represents so few patients and they're not our MVP's not in there, Blue Cross Blue Shield's not in there, Cigna's not in there, and it's the hospital referral region, which you addressed to some degree, that UVM Health Network has many of the hospitals in the area, but Northwest Medical Center, Copley, Rutland, Canton Potsdam, they're all in that as well. And so it really can't, I think, speak to an individual hospital. It is a really interesting paper, though, because it definitely discusses, and I think you actually talk about this a little bit in the appendix. It discusses, the variability of pricing between different payers and how and there's really poor correlation, which I think also speaks to this notion that we've been saying for a long time in Vermont, we're a low-cost Medicare state with the assumption that we're a low-cost everything else state. And that correlation is not strong. And we see that because we see in Kaiser Family Foundation that we are in 2022 number 7 for cost for healthcare spending per capita. So we are not a low spending state. We are a high spending state. We have very high commercial insurance rates, some of the highest in the country, and very high per capita spending. All right, and the last sort of my monologue pontification, and I apologize, is on the RAND pricing. And I actually am very, so I agree that when we're trying to compare a hospital to a hospital, that the underlying Medicare reimbursement is a bit tricky for accurate comparison. So I do prefer the standardized price, especially when comparing Vermont hospitals to Vermont hospitals, because we have so many critical access hospitals and they each get different Medicare reimbursements. UVM gets different Medicare reimbursements. Rutland's been a sole community hospital for a long time. They get different Medicare reimbursements. And I think we did touch on the inpatient stuff, and in your appendices, you touched on the outpatient stuff. I believe it may have been elsewhere, but I want to talk a little bit about the RAND outpatient pricing data. So it sounds like it was in the appendix, so I assume you're all familiar with the RAND outpatient standardized pricing. Okay, and Steve, sorry, Dr. Leffler, Steve and I used to work together in the ER a long time ago. So, when I first started, he had just moved to being a CMO when I started at UVM, and so I'll call you Steve, if that's okay. But you mentioned that you think the RAND data may be not representing things well because of the services that you provide. Could you expand on that?
So, and yes, please call me Steve. One of the things you have to be thoughtful about is compare us to Dartmouth. Dartmouth does, and they're our partner on many things, and we're grateful they're here. We've worked together on many big issues. Dartmouth doesn't provide dialysis. That service has been sold off. We lose a lot of money on dialysis. Dartmouth doesn't own primary care. We do own a little less than 50% of primary care in Chittenden County, but we own that. We lose money on that service, but it's critically important to our mission, and of course we should be doing it. So you have to look at what's included in your overall service mix and what purpose, where you're fitting into the whole continuum. And so also how we've negotiated rates over a long period of time. So we've heard, experts like Kelly give us some commentary around, over time, it looks like we've brought commercial or outpatient rates up higher, and then they adjust them over time. So I think there's a lot of pieces in there that make it hard to just say, oh, this is why you're more expensive or you even are more expensive. I think it depends on service mix a lot. And Rick,
okay, so,
I see Rick's off mute. Rick, do you want to add
hold
to
on,
that?
can I ask you a clarifying question on that before we? So are you saying that that's contextualization for the RAND price, or that actually changes the RAND price?
I hope it helps explain it, but I don't want to get in trouble with Rick. So let's have Rick add some more detail. I believe it explains why we're more expensive.
Yeah, so going back to the inpatient price for a minute. So when you look at academic medical centers, for example, the inpatient services that they provide, it should be somewhat similar, from one AMC to another. Yes, there's, maybe one has a little bit more, robust transplant, program than another, but there's definitely a lot more standard kind of services that you provide on the inpatient side for academic medical centers. When you flip over to the outpatient side, however, we are unique here in Vermont, and I just want to clarify, it's not what we think is driving this is not the fact that we're losing money on dialysis. It's the fact that dialysis has a fairly high price. So if you have that in your mix of all the services that you're providing, it's a high price service, and you're comparing yourself to another organization that doesn't have dialysis, for example, that's gonna automatically create some differences between one hospital to the other. So service mix in Vermont is unique. There's most of the services, there's not a lot of services that are provided outside of the hospital. Some other, some AMCs as well, they've spun off, outpatient imaging centers, outpatient surgery centers, where that data is not under the tax ID of the AMC that's in this RAND data. So that service mix is what we believe is having an impact.
Are you saying that service mix changes the RAND price, or the service mix changes how we should think about the RAND price?
No, it changes the RAND price, because they're looking at all the services that are provided by those entities. And so if you have different types of services, it's going to impact that number.
Okay, so they adjust those prices so that you have like the standardized price. So you could have a hospital, like, say, that does so I'm thinking about outpatient services. So like really complex, high revenue generating outpatient surgeries, and theoretically with the RAND, and I think you probably have to like give it some fudge factor there, but theoretically with RAND, you could compare that to the prices at a hospital that has, outpatient cardiology and primary care only, because it standardizes all that. It readjusts that. So if you have a huge dialysis impact, like a dialysis presence in the services you provide, it's not going to change the RAND price, other than that's the price of dialysis within the outpatient commercial price of dialysis, which I think probably most of your dialysis isn't actually outpatient commercial anyways. It's probably more related to Medicare and Medicaid. So the beauty of the RAND data, and I'm sure it's clearly not perfect, but it's quite directional. It adjusts for all those things. So I think it helps contextualize the need for high commercial rate. I think with this in sort of the context of this cross subsidization that we do, but it doesn't. The RAND price in itself is it's not a charge, and it's not an average charge. It's an adjusted charge, and it's not just adjusted. It's not adjusted by age. It's adjusted by all the complexity factors that Medicare uses to adjust things. It's not Medicare revenue driven in the standardized price, but it uses the Medicare methodology for adjusting the complexity, which is skewed in certain ways for sure. Cardiac surgery skews that up. You can see Brigham's inpatient RAND price is much higher than UVM, and I know Dr. Epen knows that before I went to med school, I did cardiac anesthesia research there with Dr. Shernan, Stanton Keith Shernan, and there's what 8 cardiac ORs that are just churning all day long, right? So maybe that skews it a little bit. But it's interesting, actually, if you look at the Brigham's outpatient RAND price, it's like $340. It's like 40% less than UVM's outpatient RAND price. So anyways, I just want to make sure that we understand that RAND price is not a charge. It's the price is paid, and it's totally adjusted. So your service mix shouldn't affect your price. It's just really helpful to think about.
Yeah, I think there's more discussion there. that standardization, when we've looked at the data, we believe that the service mix does play a part in and if there is differences between one hospital to another, that does factor into the to that standardized price.
Yeah, at least when I've talked with the RAND people, there is a standardization and it may be impactful, but I think that the magnitude of the impact is probably a few percent as opposed to a few 100%. So when we look at UVM's outpatient standardized pricing, I'm sorry, Jess picked the whole list. I just picked a few hospitals that I was looking at as comparative prices. And this is by no means, this is not a selected sample other than these are the ones I picked. But UVM is 556, second highest in Vermont, top 10% in the United States. Dartmouth is 421. Brigham, is 478, 32% less than UVM. Maine Med is 366, 34% less. Albany Med is 304, 45% less. You got to keep in mind with both Albany and Brigham, their inpatient standardized price is quite high. But as I think as you are aware, your outpatient revenue is really driving the bulk of the revenue. So even if they have a high inpatient price, if we gave you their prices, you would still be making several $100 million less in revenue. And Albany Med 304 and based at 45% less, and the Bay State Medical Center was 65% less. These are hospitals that our patients go to, except for Maine Med. But I was thinking Albany, Bay State, and Dartmouth.
David, I'm sorry. Member Merman, I'm sorry. I don't.
Yep.
So when you say that, I'm just trying to, knowing the Brigham and understanding their outpatient services and what they do with those. So it's very deliberate that they're moving services that are low cost, low acuity. So you can come into the emergency room to the Brigham and need cardiology services that are low acuity, and those patients will get transferred to Newton Wellesley. It's just part of the process of how they're utilizing their system. And so they're really very deliberate. And that maybe there's a deliberate cost piece, but it's, I think, driven by, we want to do high acuity care there, right? We're specializing in order to do that. I just don't know enough about the RAND, and I bring it up because this has been a common theme today, I would say, is that there's lots of discussion, I would say, even amongst all of you around, this is the way we ought to look at it. This is the benchmark we ought to have. How do we look at access? How do we look at wait times? Like, I invite all of you to come together in some way or assign different members to take on some of these and work with us, because I would love to establish like clear guidance and benchmarks that this is what we're going to go for, and we all understand it, and it's the common language. Or the Cooper study is from 2011 data. Let's not even talk about that. Totally like with you, but I feel like there's a common theme here around, can we come together and do this? I know we'd be more than willing to do it in any forum that you think is reasonable. We could do it with VAS and all the other hospitals, but I just feel like there's such an opportunity here that for us to come together that we haven't taken advantage of, and it would get us to our common mission and endpoint of how do we serve Vermonters better? How do we drive down costs and really understand that? Because I'm not denying anything that you're saying, but I just feel like we're not talking to each other. We're sort of, here's some data that we have, here's some data that you have, and we're not really connecting, right? Because we don't understand it well enough, or we haven't dissected it well enough, or we haven't understood what it is that you really want us to go after. But it would be great to come together and understand that and say, all right, you're going to hold us accountable for decreasing wait times now, and we understand what wait times mean. You can't count 3 months and turn it off, or whatever it was that we learned today. But so I just take that moment to pause us and wonder how we can do that better going forward, so that we can better serve our patients and our communities. Because this, I'm not sure if this is going to help us, right? Because we're not seeing the same world, unfortunately. So
I think we're trying to. Well, no, I think you're right. I think I think that we see things from different perspectives. We see the impact of high commercial rates on people in Vermont and how destructive that is. And you see the impact of, you need more commercial revenue. And so we're trying to help you see our world, which is why in guidance, and that is really, the time that we have a great conversation about this, we talked about RAND. And I would encourage you to like dig through the methods and dig into it and try to understand. I'm sure they're happy to talk with you. They're very accessible people. And they came and spoke earlier to the board. And yes, it would be really, really handy to have a whole bunch of benchmarks, and I think we're working towards that. But the reality is that, I agree with Dr. Holmes. The literature showing that the rise in cost of healthcare is heavily related to the rise in prices in healthcare.
I think the challenge that we have is I promise I'm going to stop, but is that when we're both looking at the same set of facts, we're not agreeing on it. And I'm with you. I think I want to see it the same way so that we can move in the same direction on it, but we really aren't agreeing on the fact stuff. And I'd love to agree on the facts to move us forward. And I think there's so many different studies to follow up and look on. Like, let's agree which ones we're going to try to do and really understand that and move forward on. I'm with you. I'm actually agreeing with you that we've got to figure out a better way to do this. And so thank you. Thanks for listening.
Yeah. Well, thanks for bringing up the view. All right. So we went through RAND. Oh, so I'm just going to bring, since you're going to learn a lot more about RAND when you dig into it, RAND also has prices on outpatient services. And one of those, it does endoscopy, cardiac catheterization, CT, MRI. And one of the outliers for UVM is pretty high on all of them. But the CT, MRI standardized price is really high. And you noted that you wanted to be held harmless for the labor associated with hiring techs to run CT and MRI after hours. Do you think you would lose money on running CT and MRI after hours, that you would need to be held harmless for those techs?
In terms of that statement, it is about the additional cost that you would see in our cost structure, because that type of labor will be higher than our standard labor. It is intended to ensure that we can meet, or at least get close to, meeting the needs of our patients and reducing wait times. But the point of that is that it will come at a higher cost because there simply is not enough staff to perform those. So that's the component that, based upon what we would normally pay, you're going to see a cost increase associated. And in terms of the concept of bringing down cost, we would need to be held harmless for that, because that is not totally within our control. If we're obviously we negotiate on rates, and we've done an excellent job with that, but that is something, if we meet the needs or attempt to meet the needs, that costs will rise more than what they have historically, because of the type of labor we're having to use.
And you would get commensurate revenue for that, though, right?
No, the revenue would not change. So if we had to pay $100 an hour for a tech at a contracted rate, and these are not real numbers, so I do want to go on the record to say that these are just easy to calculate type of assumptions here. If you had to pay a contracted tech 100 and you paid your own staff at, let's say, 80, the cost delta is what we're referencing, but the reimbursement that we get for that test doesn't change when we bill and receive reimbursement.
But you'd be doing, you would have additional scans, would you not?
We would, at a lower margin. So the point being that not all net patient revenue is equal, because you will have some costs that will have to be covered by the same net patient revenue, and some of those costs are higher.
Okay, I understand what you're saying.
So it doesn't drop all the way to margin. there is a cost factor associated. But the focus of that is attempting to meet the needs of our patients. And at times we have to do that at a higher than normal cost.
All right. Kristen, can you put up the payer revenue document from the I don't know if it's in the website or if it's just in the binder. I think I'm covering where documents would go. Great, thank you. Okay. So, and can you pan down just a little bit? That's good. That gets everything we need in it. Okay, so when I was looking at this, we can't see the headers of each of the columns, but the left column with the numbers is commercial, the middle column is Medicaid, and the right column, or the third column, is Medicare. And just sort of like a basic thing, when I was looking at, would one think that if you were to look at the proportion of commercial to the total on the right, that would be the payer mix for commercial?
It depends on the type of payer mix that you're looking at, Member Merman. So actually, if you scroll back up to the column headings, so there's gross payer mix, which is predominantly the one that gets referenced the most. So how much you bill out to the payer before reimbursement is factored in. So there's payer mix that's calculated at that level, and then there is payer mix that's calculated on the net reimbursement that you receive.
Okay, so that would be, the total revenue line versus the net payer revenue line.
For a payer mix, it's based on net revenue. Yes.
Yep. Okay. And actually, I think that the very bottom line here is the net patient revenue plus the FPP.
Yep.
So one thing I was also looking at this and I was trying to understand in relation to cost coverage was if you take say for Medicaid, the total gross revenue is, or total gross, this is for FY25 budget, is 783 million, and it pays out about 200 million would be what it would be after it was adjusted for reimbursements. Is that right?
Yes, that looks like that's correct. 783 down to 200. Yes.
And then for Medicare, to the right of that, it's like 1.5 billion down to just under 400 million.
Yep.
So one thing that I was surprised by on this is that it's almost the exact same proportion for Medicare and Medicaid, 74% reduction.
Is there a question, or
does that look right to you?
Yeah, when you look at so if you look about halfway down the chart there, the graduate medical education payments, hospital and physician payments. So those are those enhanced Medicaid dollars, that 25 million and the 40 million you see there. So yes, that's what brings Medicaid rates up to a similar coverage as Medicare.
Okay, because I was looking at that, I was trying to understand why the cost coverage numbers would be different for Medicare and Medicaid if they have the same, basically, proportion off of gross.
Yeah,
So
it's not a deduction component. Those are the additional payments. So if we bill something out to Medicaid, again, let's say for simplicity that it's $100, what we get back from them in just the payment is the difference in that is our contractual. So we're not getting a GME type of payment on every bill that we send out. So that's when you normalize, okay, what are we actually getting in terms of payments back on what we're billing out? The difference of that is the contractual. So that is what you're seeing above the 25 and the 40.
Okay, so you don't consider the additional Medicaid payments when thinking about Medicaid cost coverage?
So can you just reference the cost coverage number that you're looking
Oh,
at?
let's see. The cost coverage numbers that were submitted, there was a couple of different ones. Let's see here. There was one that was 58% for Medicaid and I believe 67% for Medicare that was in the OSC application. And the response to pre-hearing questions, there was a 77% for Medicaid and a 65% for Medicare. And in the appendix, just an additional, it's not a UVM specific, the AHA letter to CMS has an 88% basically Medicaid cost coverage. 88 cents for every dollar spent by hospitals providing care for Medicaid patients is the average in what you submitted in the appendix. So there's a bunch of different numbers, but what I don't understand is why, if you have the same discount off a gross, why they would be different between Medicaid and Medicare.
Yeah, so I think we'll have to follow up with, because I think those are different sources. So if we can follow up with the three, it sounds like you're looking at three different numbers there. We can explain why there may be different cost coverage calculations there.
Okay, so what? So in the pre-hearing questions, there was a discussion about Medicaid having a $60 million shortfall and Medicare having a $238 million shortfall. And I was trying to figure out how that could be calculated. If the Medicaid NPR is 200 million and you have cost coverage of 77%, then the shortfall would be 46 million. And if the Medicare is 397 million and you have I have a 65% cost coverage for that, then that would be a 139 million shortfall. So maybe you could give in a response a little bit more understanding as to how you got these numbers for the shortfalls.
So I think we're mixing and matching a couple things here as well. So what you're looking at here is not cost coverage. So the math that you're doing between gross and net patient revenue isn't cost. It's how much we're collecting based on what we've billed out. The cost coverage is looking at essentially that 200, the 200 million and comparing that to actual cost. The actual cost that we've incurred for providing that care. So
right, I understand that. I wasn't trying to say that if the cost coverage was 24% or 26%, but I was just saying that it's interesting that they're so similar. That why are the cost coverage differences? Why are there significant cost coverage differences between Medicaid and Medicare? And then the last math I was using was using some of the various sources in here that are different of the Medicare and Medicaid cost coverage compared to the revenue to try to understand the shortfall. But if you could give me more clarification as to really the Medicare shortfall is substantial and seems out of proportion to the cost coverage calculations.
Yeah, again, we're not seeing the numbers that you're comparing to the sheet here. So we'd be happy to follow up with those comparisons you're making.
All right, Kristen, can you put up the workbook? Oh, you're so nice because I let you know, and go all the way down to the bottom. And are you familiar with this rate decomposition document? Oh, it's hard to read. You can zoom in and stay on the left side of the document. That'd be great. Can you actually, this is the one off our website?
Yes, this is the one from the website.
It does say confidential at the top, so I just want to make sure that.
Yeah, sorry to interrupt. Can we just take a moment to make sure that this is the public version, not the confidential version?
I just pull it down. Thanks.
We're checking on the document that's posted to our website right now.
Let me see if I can do something different here. Let me. Kristen, could you do me a favor in the meantime and put up the questions, the responses from the pre-hearing questions? And which page is this? 11.
You want the follow-up questions for hospitals under
Uh,
UVMMC
I think
or the follow-up
so.
responses?
Follow-up responses. All right, let me see which page we need here. There's a few different things. If you could just go to, if you could just go to page 1, just go down a little bit here. And it's question 2 there. I just want to talk a little bit about, because we just came off the OSC hearings, I was very familiar with your surgical cases. So you said in 23, you performed 21,204 surgeries and procedures, which ends up being 3,972 more than FY19. Is that number right?
I believe that's correct. It said that we did 2161 more than 22, or yeah, 3,972 more than 19. Yes.
Okay, so that would give you just the quick math. I'll tell you what it is. It's 17,232 cases in 2019. Does that sound right?
I'd have to look, Member Merman, that
It's roughly
sounds a little-
4,000 less than
Okay.
21,000.
Okay.
17. Yeah.
Yeah.
So that would be almost 1,800 cases less that was used in projections based off of 2019. I think you used 19,000 cases in 2019 was the basis for all the projections for the surgery center.
In 19, we did have the air quality issues at the Fanny that really did impact the number of cases we could do. We closed the Fanny twice in the fall of 19, which was extremely challenging. And we tried to run as many of those cases as we could through the main campus, but our actuals for 19 were low. I know that.
Okay. So in Q008 response to our OSC application, you provided a table, and in that table, let's see, you had 21,635 cases in 2019. So about it's 431 more than 2023. Does that sound right, or does that sound like too many cases?
I'd have to look at the submission. I
Yeah,
can't really comment without looking at the.
I think I'll cut to the chase on this. Is that essentially, you guys in your you did. It looks like there's 2 different ways that you've reported cases to us for surgery throughout the OSC process, and this appears to be the one that includes procedures but not endoscopy. And so, if you add up the Q008 but exclude Fanny in 2019, you end up with the number that you're saying here, 3,972 less. But you actually did more cases in 2019 than you did in 2023 from the submissions. You actually did more cases in 2017 than you did in 2023. So this is I just want to say that this data is pretty misleading, and I hope you haven't sort of, high-fived each other for, wow, we just did 4,000 cases more than 2019, because the data you submitted, it looks exactly like you missed adding the Fanny Allen cases into your baseline number of 2020, so in 2019. Just want to make sure that correction was there.
We'll have to get back to you on that.
we could probably actually use, Kristen, were you able to get a workbook, or is that still kind of in process?
We're still verifying.
You know, if you go to page of this document, if you go to page 11, I think we can get to my question. So this is sort of a partial workbook that I think can get to most of some of what I'm curious about. Okay, so what I'm curious about is what makes up the all other category listed on the left under total NPR, just below major commercial.
There are several things that flow into that. I do know that we also have Mark Stanislaus in from the budget team as well. But I'll speak to a few of the things that are in it and ask Mark to add in for anything I might have missed. So we certainly have the self-pay in there. We have workers' comp in there. We have our own plan in there. Mark, have I hit most of the major categories? Are there other things we should be referencing?
That's also where denials goes through also. And there might be a very few subset of payers that we don't normally negotiate with. It's kind of a catch-all category.
It's a huge amount of money. Is this other than sort of the 3 or 4 biggest payers are included in that, or I mean, can I?
We can get you that.
Do I think about it as
Get you that
commercial?
back. No, that's not. So we will get you that breakdown of that other category.
Okay, because one area that I think is interesting here is if you look at column F, the rate assumptions, it works out to about a 2% rate increase on all other and a 6.7% rate increase on major commercial. And so that's what I was trying to figure out is, are there certain insurers or are there certain entities that you're getting a lower rate increase from in the all other category, but you're not getting that commercial rate in the projected FY25 budget as submitted in the major commercial category? So that would be super helpful. One other thing that I don't think I need to have the other document up for that we can just talk about is I'm trying to understand the distribution of your professional revenue if I was to attribute that to inpatient or outpatient. Do you know roughly when looking at your professional revenue how it would break out as inpatient or outpatient revenue?
I don't have that member Merman, and I think the only way we may be able to provide that is looking at the site of service on where the service was provided. It's not something that we routinely include that breakdown as part of our internal reporting. So we'd have to create a specific analytic to create that breakdown.
I don't want you to do that extra work, so don't do that. On this document, we don't have Medicare Advantage. It looks as if it's included in Medicare, looking at the dollar amounts.
Or in all other. It might be, is Medicare Advantage, Mark, you would know, is it in the all other or is it in?
It's in commercial. Or no, I'm sorry, it is in Medicare. It is in Medicare. I'm quite certain of it.
Yeah, in this document, it's in Medicare, and the other version, it's broken out separately, and the commercial and the all other and the Medicaid numbers are steady. So I think, yeah, it's in Medicare here. Do you ever negotiate with Medicare Advantage plans for prices that exceed, the typical 105% of Medicare charges?
Would that be Kelly or is that you,
Kelly?
Rick? Yeah.
Yeah, Kelly can answer that question, Member Merman.
Yeah, hi, Member
Okay.
Hi, Member Merman. We do negotiate with the Medicare Advantage plans. They are some of our more difficult plans, and what we actually focus on mostly is reducing the administrative burden, because how they pay, which is actually less than Medicare, which you've heard before, I believe, is due to denial of claims. But this is high level. I wouldn't want to get into specific negotiations, but we do negotiate with them.
And
Do you ever
Member Merman,
negotiate?
if you do need actual numbers, Member Merman, I'm afraid that's something that we'll probably all need to talk about in executive session because it is proprietary and competitively sensitive.
Okay, could you talk about the last year's negotiation prices that are in the price transparency document that is publicly available?
Could you reference that? I'm not sure what you're referencing.
Well, in the budget submission, you link to the big mega file in Excel with 30,000 different codes that has all the different payers and what the negotiated payment rates are. I just skimmed it. I didn't look through it deeply, so I'm just curious if it's in there. If not, we can do it. I'm actually just looking for broad, non-specific questions. So I don't think it really needs to be in an executive session. But if you don't feel that the question should be answered here, Mr. Miller, if you want to intervene, please go for it. I don't want to cause sensitive information.
We have no objection to giving you the information that you're looking for. I don't think, given the nature of the question, any of us could tell you whether it's calling for proprietary information right now. I think if we want to ask the question, perhaps in follow-up, we can then work with your counsel to determine whether the answer is something that we need to provide to you under seal or as available to the public.
Sure. My question and follow-up will basically be, do you ever negotiate with Medicare Advantage plans to pay rates higher than, I'll say, 105% of Medicare? And then I can ask that in follow-up.
And we will need to answer that under seal, and we'll make the appropriate request through Mark to do that.
Okay. And I think Kristen sent me a message that you can pull up that workbook now.
Yep, just for the record, we had an opportunity to talk offline with your counsel as well as internally, and this is the non-field version of the document, despite the confidential header at the top.
Great. Well, funny as it is, I think that I was able to talk around all these things without actually needing the document while we were waiting for it. So I think I'm good with that. But thank you, Kristen. And I think, just running through my other questions that I wanted to ask. I just had one last question on the Medicare wage index. And I'm just trying to understand this. Maybe Ms. Peakley, you have the best understanding of this. So if you pay higher wages for 4 years, Medicare gives you, my impression of what you're saying is they give you higher reimbursements. Is that how it works?
It is taken into consideration with the area, so it factors in with area wages and becomes a factor. It does not mean they match dollar for dollar 4 years later.
Great, thanks. And then one other question, because this came up, I think, in the narrative and then today, is this insane tragedy of all these xylazine wounds and the long hospitalizations that many patients have with these xylazine wounds. And I don't know much about Medicaid payments. We don't oversee Medicaid. But if a patient who, I would assume a lot of the patients who have prolonged hospitalizations with xylazine wounds may have Medicaid. Many of them may have Medicaid as their payer. Do you get a per diem for those patients, or is it more of a DRG based, or is it because it's the fixed prospective payment, there's no additional payment to cover this epidemic of xylazine wounds and very extensive care that needs to be delivered to care of these patients?
we'll have to get, I'm pretty confident I'll have to get back to you, Member Merman. I'm not, I mean, one of the issues, and I'm sure you're aware of this, is many of them stay in the hospital for 2 days, sign out. 3 days later, they sign back in, they're in and out. So we'll have to get some information on how most, I think a lot of them are uninsured completely, but for the ones who are on Medicaid, we'll have to, we'll get back to you on how we're getting, whether it's DRG or it's under the capitation of the all-payer model.
Great. Okay, thanks. Sorry for the hiccups on the exhibits, but thank you so much, and thanks for being here.
Thank you.
All right, we still have Member Lunge and the healthcare advocate and public comment. So why don't we just take a quick 5-minute or 6-minute break? We'll come right back at 5, and I think we're okay on time, a little over, but thanks for your patience. So we'll be back at 5, a short break. All right, Member
Sorry,
Lunge,
I
oh,
need
sorry.
1 minute. I apologize. I had to call back in.
Oh, sorry, Michelle. Take your
Oh,
time.
my apologies. Okay, I think I'm on now.
Okay, I don't know how to see who's here anymore, but,
I'm here.
okay, all right. We'll go back on the record and turn to Member Lunge. Thank you.
Thank you. Hi, everyone. Thanks for your patience. I have 3 areas I wanted to talk about. The first is mental health. I appreciated in your follow-up responses that you will be submitting an interim report regarding the 18 million in funding. But I was curious if you could just give us a sense of how much of that funding will be expended in the first year. I noticed in your narrative, you spoke to both the mental health urgent care and the embedding mental health in primary care, both of which were in your plan for those funds.
So I know the mental health urgent care is opening, I believe, late October. And I know we have mental health embedded in almost all of our primary care offices. I don't have the exact dollars in front of me, Member Lunge. Judy, do you know how much of those dollars we're spending this year?
We can look at that and provide a response. So I
Great.
do not have the number off top of our head.
Okay, thank you, Judy. We can do that as a follow-up. I'll just note in your May 29th, 2023 plan, the estimate was about 9 million for the first year. Thank you. In your narrative on page 26, you discussed some early data from your care management program or pilot, which included a 42% reduction in ED visits and a 41% reduction in inpatient admissions. In terms of these initiatives, it looked from what I can recall from your narrative that this was a pilot. When are you anticipating on expanding that pilot? What's the timeline, and how have you reflected the savings in the budget request?
Care management is part of the PHSO. We have it embedded in multiple of our emergency departments. I would say it's somewhere between a pilot and actually something that we're rolling out. So we are offering it broadly. We've seen good results. And it is a critical part of providing, value-based care.
Thanks. And do you have any savings estimates that you're projecting for the program?
Have you seen data, Judy, on savings?
All of the plans are built into our budget, but we'll have to get a response to you in terms of the detailed data behind that plan.
Okay. Thank you. And then my last question is related to, and I apologize for the whining dog. If you can hear the whining dog, she's about had it with the hearing, I think. So on page 24 of your submission, you showed a chart which indicated an increase in self-pay or uninsured. The chart is for inpatient. So you've spoken about in your submission about efforts to move people into your free care policy. Can you speak to your efforts? Or I guess I should ask, do you have efforts to get people signed up for Medicaid or into the exchange plans if they've fallen off Medicaid due to redetermination?
We do not personally sign them up, but we do work as part of our financial assistance team to educate and provide guidance if we see that there's a potential possibility for them to be qualified for that. So we do provide guidance and education, along with while we're assessing them for whatever financial assistance they would qualify with the medical center.
Okay, so you don't have navigators or anything like that embedded in your current hospital?
So we have financial counselors, member lunch. So I think that
Yeah.
that's probably the equivalent of navigators that do help patients with those financial issues and applying for. Again, we can't automatically make it happen,
Sure.
but we certainly provide the guidance.
Okay. All right. Thank you. Those were my questions. I'm all set.
Thank you very much, Member Lunch. I'll turn to Healthcare Advocate.
Hello, can you hear me?
Yes, sir.
All right. Thank you, Chair Foster, and thank you, UVM. Given the lateness of the hour, well, first off, I want to recognize that we had a list of questions and that the board has done a particularly good job of ticking off all of our questions. So we don't have any questions for this afternoon. I do want to recognize we've been focused on the free care and bad debt numbers, and I want to recognize UVM's numbers are good from our perspective. That is the relationship between the two, particularly in 24 so far, is looking pretty strong. I also recognize that UVM is has worked well with us and worked well at complying with Act 119. So appreciate that. I wanted to just in a very different direction, a different way than I think Chair Foster started the day, his questioning off a number of hours ago, talk about the impacts, what it would mean for Vermont if UVM was granted what they're asking for here, what you're asking for here. What would a 7.91 commercial rate increase do to our health system, do to our community? And I understand that you see this from a very different perspective, but from where I sit, it's unfathomable. It's just hard to imagine a decision, a decision to give UVM that big a commercial rate increase means a double-digit premium increase next year. It means that we've further destabilized our carriers. Blue Cross's reserves. Blue Cross's reserves are already concerning, and it means that that MVP's ability to break even in the Vermont side of their market is also seriously challenged. It's true. It's been noted. It's true that the combination of the enhanced premium tax credits and the silver alignment, the way that we've rated this year, has provided some real relief in the individual market. But man, the small group is in trouble. Small employers are in trouble. I tend to, given my past, focus on the nonprofit sector. Talk to your friends who are running small, attempting to figure out how to provide a basic benefit of insurance in the small group. And you'll hear a horror story. Let alone the impact of steering this much money to UVM on the rest of the healthcare sector. I guess my high-level statement, I'm not expecting a response back. I just want to say what it looks like from my perspective is the impact is of this high of an increase is destabilizing for Vermont in many ways. I know I heard you say very clearly, this is what you need. to run the business the way, to run the hospital the way you believe it needs to be run. But from where I sit, it's hard to fathom continuing down this road and what it will mean for Vermont. So I think I'll cut it off there with that high level statement. I'd welcome a response if anybody wants to give it. I also don't expect one.
So, Mike, thank you. Sonny, Ethan here. I just really quickly, I totally appreciate your perspective. We do talk to employers. I think the same things you're hearing. I don't know what you think we have at our disposal to kind of get there. I can only say that I think sort of damaging what we can do or what we try to do for our communities and our patients while the other issues are going on does not solve the problem that we have. And so, yeah, I think it's really hard. I think we've got to figure out how we're going to serve our patients equitably across our state. It isn't clear to me. There's only one way we can do it. I think Steve's been espousing this, which is we need to come together, look at what we can do, what we want to do, what we don't want to do, and all reach agreement on how we do that best for all Vermonters. So thanks for your comments. I hear you. I really do.
Okay. Thank you, Mr. Fisher, and your office for all your work on all these budgets. It's always exemplary, and we really do appreciate the look and the work. I'll take public comment via the raise the hand function. Right. Seeing none. Thank you everyone for coming. I have two quick questions. I guess really for the CEOs. Oh, sorry, Sharon Gutwin. Go ahead, Ms. Gutwin. Sharon, are you there?
Here, hold on.
No problem. I think you're muted still, though. You might.
Thank
There you
you.
go.
Thank you, everyone, for the discussion. And I won't be long. I do hope, as I hear, we have to come together to remember the other half of the healthcare system, which is the community base, the private sector. We are left out of the discussion and regulation because we're not regulated, but we are incredibly affected. And when you think about the affordability and accessibility and quality, right now we have it working, but we're being choked because the more healthcare dollars that go into the hospital, the fewer there are to basically keep us afloat. So if we lose our independent care, that just puts more of a burden on the hospital. And I hear there's good reason why we need to think about investing outside of the hospital to keep people from staying there or even getting there to begin with. So just be mindful. I'd love a call and be included at the table of discussion of how we can work together. I mean, the hospital is critical. There's no denying that. But you can't have a viable hospital if you don't have a viable community healthcare system. The UVM is a mega hospital, and I used to work at it, and I have a lot of friends that work there still. And I do hear there is room for improvement in efficiency. I hear there's room for improvement in the culture of the business. Any large organization, doesn't matter what industry, comes with bureaucracy, and that's expensive. It's also incredibly difficult to make change. In a business, I own the rehab gym, and it's small. I have 3 locations. We're the #1 provider of outpatient care and physical therapy in numbers. But I can make a change literally overnight. And also I'm more apt to innovate in doing so. Whereas a hospital of that size, I mean, ever since I've been involved in the Green Mountain Care Board, honestly, I've never heard anything different than what was presented in the discussion that came before all of the reports. I just don't see anything different. I don't see that it's going to get better. I haven't heard anything that tells me that next year we can expect things to improve. And we're at the end of the road as far as viability. Being the small business that I am too, a 22.8% increase that's being borne on my staff. I can't pay salaries that come even close to what the hospital is able to pay their providers. So we must come together as a group. We can't think of just supporting one without the other branches. And then one other thing. Oh, just when you talk about, the financials and how it's helping patients to get subsidized, even in the independent market, that is coming from taxes. And that hasn't really been mentioned here. Healthcare cost is borne by all of us, whether we're getting the free healthcare and still paying taxes or we're on commercial. So it is cost shifting. It is all cost shifting. In other words, yeah, you can lower the cost for some people in the population, but that cost is borne on the ones remaining. And the ones remaining are faced with the 22.8%. And then they're not going to afford it, so they won't be insured. That commercial market of insured patients goes down and onto subsidies. In other words, I don't know how we haven't had more discussion of this is a spiral, and it shows no sign of at all relenting and getting better. So at the bottom of it is a catastrophe. It's an implosion or an explosion. I don't care. It's a destruction. And so please, even though regulation is really only necessary when you're not able to meet the needs of the population. And there's no evidence that any of us in private care are meeting the needs. So regulation doesn't serve a purpose. Regulation is meant to keep big business from overriding the small businesses so that we all stay competitive and we help each other. To build a better community. So please, let's work together. Thanks.
Thank you. Any other public comment? Ms. Gutwin's comment made me think of something. We have our rate review public comment hearing maybe about a month ago. It's really impactful. And I just wanted to ask Dr. Epen and Dr. Leffler if you've had a chance to watch any of that hearing, because I think Mr. Miller has probably never had this experience, but as a lawyer, I will always go in and think I'm going to win, and I lose a lot of the time when I think I'm going to win. And I win when I think I'm going to lose. And the reason for that is because I don't have a good understanding of the other side's arguments. And this isn't like an argument, but understanding Ms. Gutwin's point or the payers' points, Blue Cross's point, or the people who pay the commercial insurance is where we sit. And I fear sometimes that how we approach this problem might be out of the left field for people because maybe they're not as invested in some of these other processes that we're doing. So I guess I don't need to ask you, but I would highly, highly recommend and say it's incredibly valuable if you watch those hearings. They're really impactful. And then also we get a massive amount of public comment on the rates and the hospital requests. I really recommend that the executives, the leadership, read those and take them to heart because I think it'll help put this in context a little bit better. And then lastly, we had a budget order last year, of course, and a lot of the budget order was about how the care board didn't find the submission credible or reliable. And I just wanted to point that out and hope that you read it. Everyone read it. I hope your board read it. And the point is that this process is a regulatory process, and it's the hospital's burden to put up information to convince the regulator that what it is requesting is appropriate. And it's whatever data you rely on needs to be reliable. And when we check it, it needs to be something that we find convincing. And I just want to level set as to how we actually do our work on that. And I thought that opinion last year kind of laid that out pretty well, that what you put up to us, we have to check out and find credible, and that helps support the submission and the ask. And then just, again, being mindful of all these competing difficult factors. And I appreciated your work today on the UVM side. of sharing all of the nuance to so many different things that we're looking at and the complexity of all this, of even Dr. Leffler, how you're describing some of the quality issues. I really appreciate that very much. And that was important context for us of understanding your situation. But none of us can do the job well unless we understand all these other perspectives. So thank you all very much for your time. It was a really, I thought, a wonderful hearing, and I appreciated it very, very much. So, sorry, go ahead, Dr. Leffler.
Just a quick question. I want to make sure there was a lot of follow-up. Are you going to send us the list of questions? I want to make sure we answer your questions exactly the way you want to get them back. Are you going to send us a list of questions so that we can do that work?
Yes, we had some diligent staff taking notes, and we will follow up in a letter. And the timing on this is obviously always very compressed, unfortunately. We'll try and prioritize them the best we can. And if there are certain ones that you think are not really that valuable, just let us know and we'll evaluate how important we think they are. And we can work through it if there was a lot today. And I don't want to overburden you or ourselves. So we can definitely have conversations about what the board members need to get to make sure we make the right decisions. But we will send a letter.
Thank you. And I just want to make a comment. I'm sorry, but
Please.
Mike, I heard you. We hear from the public all the time as well. We want to make sure that we're providing healthcare to everyone as cheaply, as efficiently as possible. There are many, many things in our budget that are pretty much locked. Most of our labor costs are locked now in contracts. Pharmaceuticals are locked. I firmly believe the state of Vermont together, all of us together, can have an impact on commercial rates and really make a difference. But we have to do it in a way that makes sure that we meet the needs of our patients. Not having the dollars we need will not help the people who have cheaper insurance if they have to leave the state to get that care. So we are committed as a medical center and a network to work with our regulators, the state, and all interested parties to figure out ways to reduce the commercial rates. I'm confident, even though we have a demographic challenge, that we can make some differences. Thank you.
Great. All right. Well, thank you everyone very, very much. I always forget when I'm supposed to do in which hearings. I don't think I need new business or old business, so I'll just move that we adjourn.
Second.
Second.
Okay, and all those in favor say aye.
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 And Michelle, thank you very much. We can go off the record. Aye, and we are adjourned.
Okay, we're off the record.
Thanks, Michelle.
You're welcome.